We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to A Pinch of Salt, a series of podcasts produced by the ERA. I am Dr. George Kosmadakis, a nephrologist from France, and the subject today is infection prophylaxis for renal transplant recipients in 2025. Infections remain a common complication of solid organ transplantation and are a major factor of morbidity and mortality in renal transplant recipients. The incidence of infections in renal transplant patients is directly related to the net immunosuppressive effect achieved and the duration of the administration of immunosuppressive therapy. The major types of infections can be categorized according to the time post-transplant. Our guest today, who will help us clear up this subject, is Dr. Ilaria Gandolfini from the Unit of Nephrology, Department of Medicine and Surgery, University of Parma, Italy. Ilaria, welcome to A Pinch of Salt.
Thank you very much. It's an honor to be here, and thank you for the invitation.
I should tell you that Ilaria is based 2 or 3 kilometers from the Central Bureau of ERA, so it will be a very close discussion. So I'll start away with the first question, Ilaria. Could you please describe the landscape of infections in renal transplant recipients in 2025, and have things changed in the past few years?
So, of course, apart from the COVID-19 pandemic that continues to cause morbidity in kidney transplant recipients, it seems that the timeline of infection seems to be changed in the past decade. Talking about the first post-transplant year, there is a recent Swiss prospective study on more than 2,000 solid organ transplantation, of which 1,600 were kidney transplant recipients, and they confirmed the cumulative incidence of infection after transplant with a focus on kidney transplant recipients, so they have more UTI, of course, and CMV infection. But they detected a stable rate throughout the first post-transplant year, especially of these two infections, not any longer during the first months. And this difference can be secondary to various factors: donor, recipients, characteristic, they're elderly with more comorbidities, previous immunosuppressive treatment, previous transplant. We are using an increased immunosuppressive regimen compared to the 1999 or 98, where the first studies on the infectious disease in kidney transplantation were published, our milestones. For example, when we started to use more tacrolimus and cyclosporin, we experienced more BK virus infection, but also we are using more prophylactic agents, for example, for CMV, pneumocystis, that often delay but not eliminate the normal appearance of infection. And what about donor-derived infection? So while unexpected donor-derived infection nowadays is very rare, and it is like a cluster of infection from recipients from the same donors, the use of donor with the documented infection is quite common and is giving excellent results. Now we have a few programs, like, for example, HCV to positive to HCV negative recipient that is they are going on in some countries, in which the recipient agreed to take the increased risk and informed consent. But this is mainly thanks to the availability of the new super effective and well-tolerated direct antiviral agents. And also we have some preliminary data on HIV donor positive into recipient positive that looks promising. However, there is a kind of strange things in which they reported a rejection rate that is increased compared to donors HIV negative into positive recipients. So the reason is unknown. We have to wait for the results. What about after the first post-transplant year, mainly the changes are secondary to the treatment. So we are treating more rejection. We are, and in this case, we have documented flares of viral, nosocomial, opportunistic infection that were not detected before, especially in subset of patients, elderly with diabetes, hypogammaglobulinemia. For example, there is a new paper on belatacept converted patient, and they reported a new peak of CMV, especially in donor positive to recipient negative serology and elderly patient. So then again, we have an increased diagnostic capability, so we can give a name, a picture to previous unknown pathogen, and in the end, our patients are not any longer wrapped in a cotton wool as probably kidney transplant recipient of the 1990s, where they are traveling a lot. We have also climate change, global trafficking, a lot of factors that are changing the infectious disease world also in our patients.
So even though our knowledge is improving, due to the fact that we have an extension of criteria concerning the choice of donors, we have a little bit heavier immunosuppressive regimens. We can see some displacements in time of opportunistic infections like CMV, and of course, we have a larger choice of donors with HCV positive and HIV positive donors, some of them in mostly in research setting. But I think that the fact that transplantation is evolving and we are really trying to use the maximum of the pool of donors, we will pay this later on with a change in the profile of infectious complications post-transplantation. So that guides me to the next question, which is, which are the challenges in treating infections in renal transplant recipients today?
So I think that the first challenge is the diagnosis, especially when there is no transplant physician there. Because kidney transplant recipient can have milder symptoms or atypical symptoms compared to the general population. They can have mild laboratory abnormalities like leukocytosis can be absent. And even in some patients like tocilizumab treated patient, even the C-reactive protein is not elevated as expected. They are suffering from many pathogens that are not frequent in normal individuals. So we have to think about them. And despite initial or atypical symptoms, the conditions can deteriorate quite quickly. So it is fundamental to do a diagnosis with cultural test, even sometimes a little bit more invasive than the general population. We have to think about, for example, bronchoalveolar lavage or liquor test, even if at the beginning the symptoms could be mild, because we have to know what we are facing and which best treatment to choose. And we have to consider the drug adjustment for kidney function, the drug-to-drug interaction, because we have very sensitive drugs, and there are other problems like sometimes we have to decide whether to reduce or not immunosuppression and to balance the risk between infection and rejection. And further, there are some pathogens, like, for example, for non-tuberculosis mycobacteria, in vitro sensitivity tests are not standardized, so they cannot reflect in vivo sensitivity and resistance to antibiotics. So we have a lot of problems, but I think that the multidisciplinary team approach for transplant recipient are the winning hand that we can give to our patients.
So multidisciplinary approach in order to treat this complicated group. We have POSI or asymptomatic picture for a lot of situations. We should be a little bit more proactive in our diagnostic approach. And also we should pay attention concerning the interactions with immunosuppressive agents. And we certainly depend on the evolution of infectiology, as you say. So what are there any emerging infectious risks?
So, talking as an Italian doctor, the new multi-drug resistant bacteria are our main enemies, like in Greece and Southern European countries. So that's true that now we have new antibiotic treatments that are available for these pathogens. They are less nephrotoxic than, for example, aminoglycoside, but sometimes they are neurotoxic, so we have to pay attention to that. But I won't be talking about all the new antibiotics today. Another emerging infectious disease can be Candida auris, another multi-drug resistant fungi that is spreading all over the world. Now we are facing the new wave of H5N1 influenza. We have new arthropod-borne disease, secondary to global warming, global trafficking, for example, West Nile, dengue, especially at warm temperatures in Europe. And there are also once geographically restricted mycosis and mycobacteria, for example, coccidioides, paracoccidioides, are spreading all over the world. For example, in the Washington state, there has been a locally acquired coccidioides pneumonia in the last decade, whereas before it was like in Central America and the Western coast. So especially in the presence of, for example, skin nodules, arthralgia, we had a lot of patients, not a lot, but too much, patients with diagnosis of recurrent gut. And in the end, doing cultural tests, they end up with a diagnosis of non-tuberculous mycobacteria or other fungal disease. So we have always to think about even strange things in our patients.
Right. So we should pay attention to multi-drug resistant bacteria, especially in the Southern Europe, for which thankfully we might have some antibiotic treatments. The Candida auris coccidiosis might be a challenge. We have also the diseases associated with climate change, and there are also some diagnostic challenges associated with a typical clinical picture of the diseases. So these are really emerging infectious risks. And what are the emerging treatment options for infectious complications in renal transplantation? So you talked about the problem. Which are the answers for this?
So I will start with the big window of CMV. So as a diagnostic point of view, so not for a an alternative strategy to CMV. So there is the preemptive strategy. It is not new, but more spread across the European centers, in which instead of doing a prophylaxis with antivirus, the patient undergo quantitative assessment of the DNA weekly and receive the treatment only in case of documented replication. This strategy is very good because we are not giving drugs, and so toxicity, especially leukopenia, that then is forcing us to stop mycophenolate, increase the rejection risk. However, it cannot be applied to all centers because not all the centers can perform weekly tests for at least 3 months, okay? And of note, since it is spreading through all the centers, we have to remember that preemptive strategy is not protecting against other herpes virus, like valganciclovir was doing. So in case of donor positive, recipient negative, we have to do a prophylaxis, for example, with acyclovir. Then staying on CMV, there are many emerging tools to monitor the cell-mediated immunity. for example, CMV quantiferon, show that we can stratify the risk of infection after transplant to guide the prophylaxis, to stop previously the prophylaxis without having a reactivation, especially in intermediate risk patients, so the seropositive recipient. While the data on seronegative are not that robust, probably we have to wait for more immune marker like TORC adenovirus associated with quantiferon CMV, or testing on other cells rather than only CD8 positive T cells. Then we have new drugs for CMV, prophylaxis and treatment. Prophylaxis, letermovir, will probably make the change. In fact, he's doing a kind of revolution in bone marrow transplant recipients. The pro is that it's very well tolerated, not associated with leukopenia, and it does not need for adjustment for renal function. But of course, it is very expensive. It is not reimbursed from all countries, for example, in Italy. It inhibits CMV replication at later stages, so we can have anemia, falsely positive anemia. So probably we will need an implementation of new markers for CMV active viral replication, like RNA or the old PP65 antigen. Letermovir can have drug-to-drug interaction with CNI, especially with cyclosporine, with need for a mild dose adjustment. And again, it is not covering against other herpes virus, so we have to think of apart prophylaxis. And it is only approved for donor positive, recipient negative, but not for time of treated patient. And letermovir cannot be used as a treatment because of high rates of resistance. But we have another news regarding refractory and resistant CMV infection, that is maribavir, a very well tolerated antiviral agent, and it does not to be adjusted for renal function. I want to spend just few seconds about the difference between refractory and resistant CMV. Refractory is a clinical definition, so the lack of improvement of clinical signs and symptoms after 2 weeks of appropriately dosed antiviral therapy. So that's the point. Often refractory CMV disease are in reality aganciclovir or valganciclovir underdose treatment. And on the contrary, CMV resistance is a genotype documented resistant, performing few specialized centers, and it is very rare. So, but both for refractory and resistant, we can use in case maribavir. Last exciting option are the that will be, I think, soon available for many several viral refractory disease, is like cellular therapy, for example, posoleucel, an off-the-shelf multi-T cell therapy specific for BK, JC, EBV, CMV, HHV6, and adenovirus. Early published data on BK viremia and nephropathy in kidney transplant recipient demonstrated that it is safe. It is not attacking they're not attacking our graft. And however, the result on the reduction of BK viremia seems to be less encouraging in contrast to earlier observation. So let's wait for the result, but the next result, but I think this will be a very good option in the future.
So this is an ongoing process, and the future looks very promising concerning prophylactic and therapeutic treatment of infections, especially the viral ones. We had a serious problem, a lack of solutions concerning this problem. And that leads me to the last scientific or medical question, which is, according to Ilaria Gandolfini, what is the prophylactic therapy against bacteria, viruses, and fungi, and for how long that we could use after transplantation and after a treatment of rejection? There is a lot of confusion there, and I think every center has its own protocols. But I would like to know your protocol.
Yeah. So for CMV, actually, we are following the ASD guidelines. So for high-risk patient, donor-positive, recipient-negative serology, the prophylactic with ganciclovir and valganciclovir or valacyclovir, whatever, it is recommended for 6 months. For seropositive recipient, regardless the serology of the donor, is for 3 months. And for thymo-treated patients, normally they are treated, and we are treating as donor-positive, recipient-negative. Of course, for many centers, there are other options, as we just said, the use of preemptive strategy. For 3 months in recipient positive, we are just checking the DNA weekly, and we are doing the treatment only in case of viral replication.
Positivity, yeah.
Exactly. Or you can start the prophylaxis and do the CMV quantiferon when you see a reconstitution of the immunity against the CMV. You can stop earlier the prophylaxis. We are doing a mixture of this because we just had the quantiferon the last year, so we are starting also looking how it is. But this is more, we are following more or less the ASD guidelines. So for herpes virus, if you are not doing CMV prophylaxis, you have to think about herpes or varicella zoster in donor positive recipient negative transplant. For the guidelines says 3 to 6 months. In our center, actually, we are doing a very course prophylaxis with acyclovir for kidney transplant recipient. Probably the first month is the crucial one. For pneumocystis, so the recommendation are doing prophylaxis for 6 to 12 months again, while with the trimethoprim sulfamethoxazole, no matter 80, 400 every day, or 1 pill 3 times per week.
Depending on the renal function.
Yeah, depending on the renal function,
the
but
graft
the
function,
maximum dose, that is 80, 400 every day, or is more or less equal. While some authors mutating from other solid organ transplant like heart and lung are suggesting even lifelong prophylaxis. So we are not doing lifelong prophylaxis actually in regular patient, but of course, every time we are increasing the immune suppression, we are going back to the prophylaxis. For example, patients that are treating a rejection in the context of CMV infection, neutropenia, lupus flare. There are papers that are showing that actually pneumocystis increased risk is depending only on when you are increasing the dose of prednisone only 20 milligram daily for at least 2 weeks. So it's a very low dose actually. And so what about antimicrobial antibiotic prophylaxis before transplant? The evidence suggests, despite poor evidence, the guidelines suggest the use of first generation cephalosporin, for example, cefazolime. We are actually using a third generation ceftriaxone to cover more gram-negative bacteria, but so the ASD guidelines and all the other guidelines later on are suggesting just first generation cephalosporin. And if you have a patient on the waiting list with the TB quantiferon positivity, you have 2 options. So you can do preemptive treatment, for example, with isoniazid before or after transplant. We personally decided to do it before transplant for 9 months plus, of course, pyridoxine for the neurotoxicity, because in case of side effects, hepatotoxicity or drug allergy, we can complete the treatment with, for example, rifampicin before transplant and avoiding a drug-to-drug interaction with immunosuppressive drug that can be quite annoying. But of course, other centers are doing it later after transplant.
Right.
I want just to say, I think that we have, so probably the prevention of infection most effective is to inform the patient how to be aware of infection. We know how to prevent COVID-19. We have to keep it for all the winter time in the next years, and also to say to the patient, for example, to use gloves when they are gardening or changing aquarium, because this kind of fungal infection and mycobacterium are often acquired in this setting. So I didn't talk about vaccine because we had the episode 33 by Nina Babel that was excellent. So I suggest everyone to listen to it again, and I'm done.
Thank you for the promotion of the episode of Nina Babel. Actually, it is going very well. And well, now I will get to the most personal question, the get to know you one. Everybody says it's the most difficult. Ilaria, if you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Okay, so as a book, I will choose the Marseille trilogy by Jean-Claude Tissot. It's a series of books set in Marseille. It's like a Mediterranean noir, very well written and touching, of this melancholic couple that is trying to solve crimes among social inequities. I love it. As a luxury item, I will look nerd, but I will take another book. So it is a little bit more complicated. It is Middle Egyptian, an introduction to the language and culture of the hieroglyphs by James Allen, because I'm very passionate with archaeology, especially Egyptology, since I was a child. And at the beginning of 2020, I started a course to understand and read hieroglyphs, but everything was stuck at the 4th lesson because, of course, of the lockdown, COVID-19. So I was not brave enough to restart my study until this time. So, but on a desert island, you have plenty of time. So, and for the songs, I will choose my 2 breakfast songs. That is one, Chan Chan by Buena Vista Social Club, when I want to be relaxed and happy. And another one that is Skinny Love by Bon Iver, when I want to be more sad and reflective. So I have the 2 options.
Perfect. So, thank you so much. Dear colleagues, infectious complications are still a burden for the renal transplant recipients, as you heard, Ilaria. Active measures of hemoprophylaxis are capital for the grafted patient survival. More podcasts are to be released in all digital platforms. Take care.